Hello from Florida. We are here at the Retina World Congress in Fort Lauderdale, 2026. My name is Dimitra Skondra, and I'm a professor of ophthalmology at NYU Langone Health, and also the vice chair of research at NYU Langone Health and NYU Grossman School of Medicine. We have a very exciting panel for dry AMD cases, which I will be moderating, along with Dr. Rishi Singh. And also with an amazing group of panelists, Dr. Manja Gill from Northwestern, Dr. Matt McAmer from Illinois Retina, and Priscilla Fernandez from Hong Kong. Well, this is a very exciting time. So actually we have a panel that can discuss options, both for different stages of AMD, but also understanding better the dry AMD spectrum. So when we put these cases together, and what I want to do during the moderating this panel is I really want to bring some light to different aspects about who with geographic atrophy, like who should we treat, and what other factors would take into consideration in these decisions about to treat. Very important to make sure we don't have any masqueraders that we think is geographic atrophy due to AMD, but it's actually another condition. And then you apply a treatment if you decide to treat that is not even relevant for this specific patient. And also some new concept about the rates of progression of geographic atrophy and the potential role of exposure to antibiotics and affecting the risk of progression, especially in the setting when we're trying to understand which drugs work better, that this can be some other variables that we never think it may affect what we track down as progression rate. We're also going to talk about cases of intermediate AMD and the role of now an available option of photobiomodulation, and discussing with the panelists and the co-moderator, Dr. Singh, about when do we consider to do this treatment and not. And then also a very important aspect that this disease does not always look the same. So in different parts of the world, like in Asia, we see a different manifestation, and we have to also keep that in mind when we're discussing plans, treatments, and also enrolling patients in clinical trials. It's very exciting that we actually have something to offer to patients. The real world expectation, I think, is picking up over time as more data come out. So I think we see more people feel comfortable to using these medications and to feel that really the patients that get them, the progression of the images seems to be slowed down. But I think one unmet need we have in the field is the correlation between structure and function. And so far, we don't have very strong functional outcomes regarding that. Yes, the pictures, these patients seem to progress less, but are they really seeing better compared to those that don't get the treatment a few years down the line? There are some signals there that will be the case, but I think the community is still hesitant to know the long-term impacts. And I think the more functional data we have will make the adaptation probably even bigger. Because at the end of the day, we need to make sure our patients see better, and we're treating patients and not pictures. But I think they're very exciting that we're moving the needle to now start thinking about intervening earlier, and also treatments in the pipeline of does not necessarily need injections, but it can be more oral and systemic medications. So, and also the biomodulation for the earlier stages. So I think it's very exciting, but I think we need to become better between the structure and function and different endpoints for our patients with AMD, dry AMD, besides the vision, like contrast sensitivity or other kind of like ways to evaluate biomarkers to really pick up a functional benefit. But definitely we need to invest more, both time and brain power and money, to really understanding the risk for progression to the advanced stages and intervene in that way before it will go to patients who already lose the vision. We only have only one FDA-approved, the photobiomodulation lifestyle. So number one, I think lifestyle is very important, and actually it may be more protective than any of the other drugs we have in the pipeline or like already available. So having and trying new agents, I think we should never forget the things that we already know are protective, and I think we need to take the time to really emphasize the importance of the lifestyle and diet and quit smoking in our patients. I think photomodulation is interesting that we have something that there are some objective data besides the vision, which is subjective, that there may be kind of like protection for advanced to advanced stages like drusen volume and other biomarkers of progression and progression to geographic atrophy. So I think that's very encouraging. And the more data we have and longer term data we have, we'll definitely be able to really turn it down to exactly know which are the patients are going to be fit the best. I think that the gene therapy is very exciting regarding the aspect. It may take some of the treatment burden, but I don't know yet if we can tell for sure that we know what is the best thing to put in the gene therapy. So I think gene therapy is exciting as a way that, as a field, we're probably going to be the first in medicine to use gene therapy as a way to provide the treatment and modify disease. But I think it's still out there, and we don't know which is going to be the best gene inside the gene therapy to either modulate the disease or make the therapeutic and make the as a factor of the disease. So I think that part is very exciting. But the excitement is something for we're going to have a modality that it can be hopefully effective, but also without requiring such a heavy treatment burden with the current agents right now. And I'm a big believer of earlier is better. And I think as a field, we need to move going from being reactive to be proactive. So I'm very excited for the industry and research groups focusing how we can modulate disease at earlier stages so that we can stop the progression to the late stages. And in that aspect, I think AI, and in addition with different ways that can affect the disease progression, like gut microbiome, which is an area of study, it will help us understand why some people progress and why some people don't, so that we can make a very targeted intervention and also address why some people respond to treatment and don't. So these are the areas that are very exciting to see the new developments, interventions earlier, and understanding why some people progress and respond to specific treatments, so that way we can really move the needle towards personalized medicine. I think that the questions that is always has the most debate and you never get the same answer is like the use of the complement inhibitors, when to start the treatment, if to start the treatment, which medication may be better than others, what other comorbidities, ocular comorbidities, we should take into consideration when we start the treatment, so we don't try to fix one problem and then create another problem. So that's always a very hot area of debate, and we see just 5 different retina doctors. So probably they will give you 5 different answers about how they interpret the literature and how they apply to our patients. But now we're also start talking about what should we be doing with our intermediate AMD patients, and I think that's a particularly exciting area of debate with this new availability of photobiomodulation, that it may be really turn out to be a game changer for our patients and regarding the need to go even to the stage of the need injection. So I think these are the 2 areas. Are we ready yet to do the photobiomodulation to all our patients? Do we need to know more? How understand what exactly is protective of what and how? And then which are the best patients to really start it and how long we should treat them? And all these questions that are still in debate, which makes it feel so exciting, and I feel so lucky to be part of it.